Yeah. Good afternoon to everybody. On this Rheumatic Heart Disease Day celebration on the occasion of birthday of late Dr. S. Padavati, I will request Dr. Sanjay Tagi, President-elect of Cardiological Society of India, to start the proceedings. Dr. Tagi, sir.
Thank you, sir. Good afternoon, Professor Minalda. Nice to see you here.
Good afternoon. Good afternoon, everyone. Good.
Today we have joined on the birth anniversary of the legendary cardiologist, Dr. S. Padmavati, who was the first woman cardiologist of the country. And she was one of the most celebrated cardiologists of the country and recipient of the highest award, highest civilian award, Padma Bhushan, from the government of India. She established the first cardiac cath lab and the department of cardiology at GB Pant Hospital. Initially started at Lady Hardinge Medical College, and then she came to establish the department of cardiology at Maulana Azad Medical College in 1967 and started the first department of cardiology at GB Pant Hospital. She focused on the modern cardiology, and apart from Dr. Sujoy Roy, and she was one of the most prominent figure in cardiology in those days. And the modern cardiology and world over, the cardiology in India was known by her name. She focused her attention on preventive cardiology and particularly rheumatic heart disease. As you know, rheumatic heart disease and its rheumatic fever and sequelae rheumatic heart disease contributes significantly to the cardiovascular morbidity and mortality in developing countries. Especially in our country, India, it is the home to 40% of all people living with rheumatic heart disease in the world. It is a sad reality, though eminently preventable, and despite possessing such a knowledge for over 70 years, rheumatic heart disease remains the most common cause of cardiovascular morbidity and early mortality in young people worldwide. Rheumatic heart disease affects the population at their most productive phase of life. Several challenges are unique to acute rheumatic fever and rheumatic heart disease continuum and contribute to its persistent, including its sequestration among the poorest and its protected natural history, the erratic availability of benzene, the drug used to treat the streptococcal infection, and the lack of concentrated effort in the endemic region. Though the diagnostic criteria of acute rheumatic fever have been constantly updated to improve the sensitivity of these criteria, the diagnosis of acute rheumatic fever was entirely clinical. However, recently, echocardiograph evidence has been added as a major criteria. The disease remains to be on decline in India, but recent studies using echocardiography and treatment of streptococcal shows that rheumatic heart disease has a high prevalence in rheumatic heart disease among school children. The focus of management has been on prompt recognition and treatment of streptococcal pharyngitis and preventing the recurrence of acute rheumatic fever with long-term antibiotic prophylaxis. However, emphasis should be placed on the appropriate management of patients with established rheumatic heart disease in order to limit the mortality caused by rheumatic heart disease. Way back on 31st March 1985, first case of balloon mitral valvotomy was done in GB Pant Hospital on 31st March 1985. It was the team of Dr. James Locke from USA, Dr. Khalilullah, who did the first 2 balloon mitral valvotomies by balloon valvuloplasty technique at GB Pant Hospital, and subsequently in that afternoon, Dr. Samitri Srivastav and Dr. James Locke did 2 other cases in All India Institute of Medical Sciences. The 5 cases were published in New England Journal of Medicine. Since then, the technique of balloon mitral valvotomy has become the initial mode of management for treatment of severe rheumatic heart disease. Emphasis on treating established valve disease is needed to reduce the rheumatic heart disease mortality. Timely heart valve surgery can mitigate the progression to heart failure, disability, and death in large number of these patients who cannot undergo surgery or treatment at this early age. Although valve repair is preferable over replacement for rheumatic heart mitral regurgitation, but it is not available to the vast majority of patients in endemic regions and even in our country. Recently, research regarding latent rheumatic heart disease management, as well as continuing work on innovative solutions, such as Group A streptococcal vaccine, are promising ways to control this preventive disease. We all should make an effort in the direction to prevent the development of acute rheumatic fever and early treatment of those patients who have already established rheumatic heart disease. With these words, I pay my tribute to the legendary cardiologist of the India, Dr. S. Padmavati. Thank you very much.
Today's topic, I would now request Dr. Pratap our President, to give talk something about the importance of this particular day. That is, the 20th of this day. Dr. Pratap Chandra Rath. Dr. Rath, please, sir.
Good afternoon, Dr. Chinna, Dr. Das, and Dr. Tyagi. Can you hear me?
Yes, please, all
Yes,
very well.
Can you hear me?
Yes, very well.
Yes.
Okay.
Clear.
Can you just, Professor Sanjay Tyagi is the right person to introduce Professor Padmavati, because both are from the same institute. I think he was closely associated with her, both professionally and personally. And can you show me the slides here? Yeah, it's here, there.
Yeah.
You can first. Okay.
2 minutes.
Yes, Dr.
Celebrating the Rheumatic Heart Disease Day. And with this introduction, I just wanted to tell you the importance of this days. See, rheumatic disease, though it has come down in India, but still it is one of the main cause of death.
This meeting is being recorded.
And almost 2% of the death is due to rheumatic heart disease. We see a lot of disability and deformity, disability, physical and because of the vulgar involvement of the heart disease. And still, though it is coming down, we don't see much nowadays, but still it's quite prevalent in the villages, in the village and rural areas. And the challenge is to detect these infections early, especially in the school children, and do the prevention. And we have the primary prevention, secondary prevention, and we should always teach this to all the doctors how to treat these patients. And we have these challenges. Also, another challenge is patients with this once heart disease already existing in society. We have many procedures now established. Balloon mitral valvuloplasty is well established, and routine valve replacement is being done. But these are the advanced case of rheumatic heart disease. Best is to prevent, and the best way to prevent is to screen the children in school and try to start the preventive measures. Can you show these slides?
Yeah.
You know, I made some slides, but I have already told. Let's go ahead forward. And this is just show the slide.
Just ask them, sir, is that they are able.
Can you see the slides here?
Yes, sir. We can see the slides. Kindly make it full screen. And one more thing, sir. Nearby two devices connected. No, there is a echo in while you're talking. So
One you connect to this connect. Okay, can you see it here?
Or else if I get the slides, I'll share from backend and you can say next whenever.
No, it's okay. Can you see the slides now?
Yes, yes, sir.
Yeah,
Yes.
yeah.
Okay, that tells about late Professor Padmavati, and she died when she was 103 years she lived, and a very fruitful life, and awarded with Padma Vibhushan. Go ahead, next one. And next slide. Change the slides. Change it. And next, this is the Indian statistics. Next one. Next one. Next one. Next one. This affects, as I already told, a lot of people, 40 million people worldwide, mostly in low and middle income countries. Every year it claims more than 300,000 lives, accounting for nearly 2% of death from cardiovascular disease. Commonly occurs in childhood and can lead to death or lifelong disability. Next one. In India, it's 40%, almost 33 million people are living with rheumatic heart disease, and out of worldwide, 13.2% million people live in India. So quite a large number of people living with rheumatic heart disease in India. And the prevalence has been reported around 0.12 to 4.54 per thousand children aged between 5 to 15 years. 44,000 patients are added every year, and expected mortality is 1.5 to 3.3% per year. This pathology, is the cause is a beta hemolytic streptococcal infection, and it affects, triggers a group. This triggers a immunoinflammatory injury to the cardiac valves, and valves are affected. Next. Prevention is the most important thing. It can be, there's a primordial prevention, reducing the risk factor for rheumatic fever in the community. Primary prevention through the effective treatment of streptococcal throat infection with appropriate antibiotics. Secondary prevention is a strategy to prevent additional streptococcal infection in a patient with antibiotic over a long period of time. Next. Challenges are low awareness, inadequate diagnosis and medical training, lack of healthcare access for treatment, especially in the peripheral areas to rural areas. Regular visits for a healthcare facility is an issue for long-term treatment. In many endemic countries, there is a little or no access to life-saving heart valvular surgeries. Next one. The most effective intervention, prevention of rheumatic fever, rheumatic heart disease, could be creating an enabling environment through policy decisions, intervention to promote sanitation, hygiene, better living condition, nutrition, and access to affordable and quality health care equitably. Thank you very much. This is the conclusion. This is the disease of the poverty. India is more than
Very good.
India is more than 1.3 billion people with wide social and economic disparities. Rheumatic heart disease will continue to be a major public health problem. There is a declining trend, especially with improving economic growth. Rheumatic heart disease draw community attention and create awareness about the disease. There is a need for establishing a population-based surveillance system in country for monitoring trend, management practice, and to formulate guidelines for initiation of intervention for prevention and control of rheumatic heart disease. Thank you very much for your attention.
Thank you. Thank you, Professor Rath, for a very succinct exposition of the epidemiological portions of the rheumatic heart disease. And with this, I must bring to the attention the fact that rheumatic heart disease is making a bit of a, let's say, late recurrence or recurrence in some of the advanced countries. On this note, I would ask Dr. Sanjeev Ashokra, sir, please give your talk on rheumatic heart disease in India, current status, and what the CSI can do. Dr. Ashokra, please.
Okay, hope I'm audible.
Yeah, clear.
Okay, my greetings from Shimla to Professor Mandal, Professor Rath, and Professor Tyagi. I'm really honored to give this brief talk on rheumatic heart disease in India, current status, and what CSA can do. Professor Rath has made my work slightly easy because there will be some repetition of slides and some repetition of the data. So, as you all know, RFRSD is autoimmune response following a strep throat infection in a susceptible host residing in a conducive environment. So, we have an interaction of a host, agent, and environment. And though it involves many systems of the body, but it is the valve injury which is the main cause of acute and long-term morbidity and mortality. Whatever we have gained in last 70 years, but we have not really found any formidable therapy to really prevent the progression of these valve injuries, progressing to severe degree of stenosis or registration of the lesions, short of giving a secondary prevention therapy in the form of penedoral prophylaxis. So it has been a neglected health problem since long, and it is the most commonly acquired heart disease in young and people who are less than 25 years. Nearly 500,000 patients get acute rheumatic fever every year, and nearly 3 lakh people are getting rheumatic heart disease, and nearly 2.5 lakhs people deaths are attributed to the rheumatic heart disease, and nearly 40 to 50% of patients who are dying in India are because of the rheumatic heart disease. And as Professor Rath has mentioned, the prevalence rates by the lowest count is between 0.44 to 4.5, but I'm sure it's clearly underestimated estimation, and the true burden is really substantially higher, which I like to highlight in my future slides. The main question we need to address on today's talk is, do we have the data or numbers, or we are knowing the enormity of this disease in India? Or second major question is, do we have the infrastructure to address this enormous situation which we are handling? Whatever the work has been done in last 70 years in India, the data has been generated from either hospital-based studies, population-based surveys, school surveys, and some data coming from clinical registries. Unfortunately, we don't have too much of mortality statistics coming from either hospital or states or medical colleges or from registrars of death and birth. All these studies have their own limitations, but this
The slide is not moving.
okay. Slides are not moving. Can you see the slides are moving?
Sir, you can able to see full screen or
Dr. Asatra,
Yes.
Dr. Asatra, can you share your slides on full screen?
Okay.
We are not
Sure,
getting
sir.
it clearly.
Sure. Hope you can see it.
no, sir. Can you make it
Can
full
you make
screen,
it
sir?
full
First
screen?
slide only.
Full screen. Please.
I think it's a full screen, sir.
Okay.
Sir, kindly stop share. Kindly stop share.
Okay.
Now click share screen.
Okay.
Hello. Then select desktop. Yeah, now it's moving. Now you can make full screen.
Okay. Okay. Sorry for the little glitch. Okay. I think hope the slides are moving. You can see them clearly. Yeah. So whatever the data source of work has been done in India, the biggest thing has been what we say the lamppost effect, which has been highlighted by Dr. Krishna Kumar. I listened to his one of the presentations. So it's something like I'm finding my lost keys right under the light, but I'm not really trying to look into the things what are in the dark. So whatever has been done in India by looking into population-based surveys or school health services has been done in areas where we already have a reasonable healthcare. We are having an established infrastructure. We have healthcare workers, nodal centers, and willing investigators to look into the database. But unfortunately, states like UP, Madhya Pradesh, Assam, Orissa, nothing much has come in last 70 years. So whatever data we are having is from the areas where we are already having some reasonable healthcare. So whatever still the data is, it's clear underestimation of the prevalence of RF and rheumatic heart disease. So the earliest studies came from later Honorable Dr. Padmavati, This was published in 1916 Circulation Journal. This was basically from the hospital-based data, and it was giving us information that in early years, in early 50s and 60s, we had nearly 25 to 50% of the patients who were having hospital admissions because the cardiac disease was suffering from rheumatic heart disease. We had the lowest figures from Vellore and Mumbai, and highest figures from my state, Shimla. Nearly every
Next
second
slide.
patient was which was admitted for cardiac condition was suffering from rheumatic heart disease. So
Next slide.
interestingly, if you see the work done by Dr. Rautre et al. From Orissa in a tertiary care health center, so he publishes hospital-based data. One study was published in 1993 and 1991, and another in 2003. And in 1991, nearly 41% patients who were admitted because of cardiac illness in a hospital setup were suffering from rheumatic heart disease, and in 2003 these were 45%. So nearly same figures over 12, 13 years, indirectly showing us that nothing has changed in a state like Orissa in last decade. So the population-based study survey was done we have 5 major studies done from 1969 to 2000. So the study done in 69, 71, 72 was basically on the clinical screening, and work done by Professor Grover in PGI Chandigarh and Lanchandani in Kanpur. They were population-based surveys done on clinical examination, and then these were confirmed by the echocardiographic, and we had a varied picture of prevalence from 0.9 from 4.5. These are just telling us the temporal trends during those times. What was the prevalent rates?
Sutra, your slides are not moving. Can you go on a full
Okay,
screen mode and this? Yeah. Yeah, just more. Just 3 slides. Sajid.
Oh, okay. Can you see it, sir, clearly?
Yes.
Okay.
Yeah.
Sir, I'll tell you, kindly stop share. Please follow my
Okay.
notes.
Okay.
Kindly
I'll
stop
do
share.
it. Yeah, I've done stop sharing.
Yeah, share screen. Click share screen.
Yeah, done it.
Select desktop or window. Share desktop, screen. Desktop or screen.
So
First
I have
option.
option of entire screen, no, on my desktop.
Yeah, entire screen. Yeah,
Okay.
correct.
Okay. Allow. Hope it's visible.
It's loading, sir. Loading.
Hope you can see it.
Kindly do it again, sir.
Hope they are moving.
Not moving, sir. Can you go to next slide, sir? Now we can see school-based survey.
Yeah.
Can you go to next slide, sir? Can you change next slide?
Yeah, I've changed trends of changing. No.
No, sir. It's we are not. You can able to see full screen or normal. Don't resume, sir. Bottom you can see play button, sir. Can you click on play button?
Yeah.
You can able to see full screen now?
Yeah, I'm able to see full screen.
No, sir. We are unable to see the full screen now. Kindly close this PPT, sir. Kindly close this PPT.
Okay.
I mean, close everything, sir. Close everything.
Computer hang করছে ক্লোজ করেছে ক্রস সেকশনের উপরে কার্সারটা রয়েছে ডক্টর অসিত স্যারের কম্পিউটার কার্সারটা দেখুন একদম উপরে ডান দিকে ক্রসে রয়েছে। এবার ক্রসিং
Kindly click share, sir. Share screen.
Yeah.
এবার নতুন করে করছি।
You can see basic, sir. Basic, first option.
No, I don't see it.
Once you click on share screen, first option will be top, first left side, basic advanced files.
No, I have only 3 options. 2 are showing a slide. Third is showing entire screen.
আছে, জায়গা হবে, জায়গা হয়ে যাবে স্যার, জায়গা হয়ে যাবে।
Then, sir,
I can only see. I have option of entire screen. No?
Okay, you what you
entire
do
screen.
is
Okay,
without
select entire screen and
you
share
read
it.
it out on the screen and tell us.
Okay.
That's the best thing.
Sir, kindly select entire screen and share it again, sir.
Okay. I've done it. Yeah. Hope,
Now the slides are moving, sir. Slides are moving.
slides are moving. Okay.
Yeah.
Okay. Sorry for really this glitch.
কিশোর
So we had data coming from the school-based service. The earlier in 17 and 80s were predominantly based on the clinical screening only. And in 1990 onwards, we had clinical screening along with confirmation by echocardiography. And a later part of 2000, it has been predominantly on by echocardiographic screening. So looking to 3 different ways of really clinical assessment, we have really different prevalence rates. So in early 70s, we had basically 3 big studies coming from the ICMR in 1972 to 75 and 84 to 87 and in 2001 to 2007. Nearly in a total cluster of really 3 lakhs school students were really screened. And we clearly shows that the declining trend of prevalence of rheumatic fever, rheumatic heart disease in the 3 studies. Then came school-based surveys, which were screening followed by the echocardiographic. This was in early part of 90s and early part of 2000. And only interesting fact I want to share is that we have a study done in Shimla, which I'll tell in a later slide. And later part of 2000, now most of the studies which were done were basically based on echocardiographic screening. Predominant work was done by Professor Anita Saxena from AIMS in Ballabgarh area in Haryana. And I want to highlight a couple of points in this thing. And previously, prior to that 2000, most of the criteria we were using were our own clinical criteria of really diagnosis, echo criteria of really diagnosis of rheumatic heart disease. But then in 2008, the criteria came from WHO, and 2012, the criteria came for World Heart Federation. So the studies use different timelines. And early work done by Professor Saxena in 2008 to 2010, she used was a WHO criteria. And look at an interesting fact that the prevalence rate reported was around 20%, but the clinical prevalence was only 0.8%. So really, echo added on to the sensitivity and specificity of really diagnosis of the RF and rheumatic heart disease. And when they started using World Federation criteria, which were probably more sensitive specific, so work done from 2008 to 2017, they found prevalence rate on the same area, the prevalence rate around 7.7%. And again, look into the clinical rheumatic heart disease, which they picked up was really less than 1%. So again, this gave us a new information that probably echocardiography is a very sensitive specific tool to really, as a screening tool to really diagnose rheumatic fever and rheumatic heart disease. And we again really shows you that in different places and different timelines, we have again one clear cut that there's a temporal trend of really reduction in prevalence of RF and rheumatic heart disease in India. And one big study which was done by the Jai Vigyan Mission Board by ICMR, really, this was done in 9 states, covering 10 districts. And unfortunately part, again, the study was suffering from what we say as a lamppost effect. So it was not really covering the poorer part of India in the form of Bihar, Jharkhand, Odisha. So whatever studies were taken up from the areas where they have established kind of healthcare structure and they had a willing investigator to really study the prevalence rates. So this is a big lacuna of this really study. But again, this showed we have the prevalence rate was, on the average, was less than 1%. This is work from my center that we have 3 data available. We had work done by one study published in 1960s by Dr. Devi Chand, and then we did 2 school health services in the same population in 1992, 93, and 2007 and 2008. And we looked into that how things have changed in nearly 15 years in district Shimla. So our literacy rate had improved from 64 to 79, per capita income had improved, infant mortality rate had really gone down, indirectly telling us that the parameters for human development index were really improving. And look into the prevalence rate of rheumatic heart disease in the same kind of population. At that time, in 1993, we had 2.2%, and 2007 and 2.8, we nearly had 5-time reduction in the prevalence of rheumatic fever, rheumatic heart disease, indirectly telling us that if we are able to improve the variables of the human development index, clearly the prevalence rates of the rheumatic fever, rheumatic heart disease is going to decline. So we have already established rheumatic heart disease registry at Shimla. It's now we nearly have a 4,000 patients with a 13 years follow-up. Again, it's showing the same trends. We have a predominantly female involvement, multivalent involvement, and peak age is in the mid 40s, and every 4th patient is in atrial fibrillation. And the interesting fact is of this registry is that less than 10% of the patients who are needing surgery are able to undergo the surgeries. Indirectly telling us, even if like our state, which has a very good healthcare indicators, still very less number of patients are able to take the curative therapies of the rheumatic heart disease. So this is leading on to that we are not still able to reduce the mortality rate in rheumatic heart disease. And the study published in NDGM in 2007, which is a global burden of disease study. So if you look into our disability adjusted life years, from 1990 to 2017, there has been clearly decline in the daily rate, and we clearly have a small decline in the death rate over this 27 years. But if you look into, sorry for this slide being in a miniature form, but if you look into the secular burden of rheumatic heart disease in different states of India, so we have huge amount of heterogeneity. In spite that in 2017, the average has been nearly less than 270, but states like Bihar, Chhattisgarh, Jharkhand, Orissa, Uttar Pradesh still is having daily of more than 3,000. Again, telling us that we are still lagging behind in healthcare, and still there is a existing huge burden of rheumatic heart disease in these states. So again, a very important slide. If you look into the age standardized mortality rate from 1990 to 2015, if you look into our neighboring China, so there has been nearly 70% reduction in the mortality from 18.8 to 5.5%. And in worldwide figures, there have been nearly 50% reduction in the age standard mortality rate. But what we have gained is we have only reduced by 18%. How China and world was able to do was they had better secondary prevention therapies, and they were able to give more curative therapies to the patient in the form of valve repairs, valve surgeries, and PTMCs to their population so that they could reduce their mortality. Unfortunately, still countries lagging behind in giving us those curative services to these privileged RSD patients, underprivileged RSD patients. So is the decline of rheumatic heart disease, is it real, or we still have something behind the curtains? We still in India having a paucity of data, as I've highlighted in my previous slides. Unfortunately, we don't have any active surveillance population-based study going on. We're suffering from still a lamppost effect. We still have a varied human development index, and some states are really doing very well, and some states are really doing still lagging behind. We had a wide disparity in socioeconomic status, and quality and access to healthcare services across states are highly variable. And even despite within the state, they are highly variable. And in townships and in a rural area, there is still having a huge urban rural gaps. And though it is clearly defining us that it is declining, but the decline is not too fast as we would have expected. Still, we are home to nearly 40% of the people who are suffering from rheumatic heart disease, and n number of patients are added every year. And probably how we can help is by overall that we need to reduce the prevalence, RHD prevalence rate by investing more into primordial and primary prevention, and by reducing the mortality rate by giving us better secondary and tertiary care health services to the patients. But unfortunately, the patients belong to majority to a rural and marginalized population, and our advanced cardiac care or tertiary care health services are really not available to these areas. So we have kind of inverse pyramid relationship existing there. So what are the challenges and the way forwards are? So this is our problem, and the solution has to come from our side only. We don't have to look to the West for our problems and a solution from them. So let's translate what we know into better practical control. So the most important point will be that we still have to look into if you look into the last major work was done in 2013. So nothing has come in last 10 years. So we have to still establish a database, do more population-based studies, establish more registries to know a true enormity of the problem in India. So still have to have a better understanding of disease outcomes, how these patients are going to progress, how fast they progress. Are we do some medical intervention therapies to really slow down the processes? And most important aspect too, that as advocacy, as I'll highlight in my slide, also that we has to really force the policymaker to run it as a national program and make it as a notified disease. We still need to improve upon our delivery of secondary prophylaxis. We need to available high quality penetrative prophylaxis to all part of India. And again, we need to provide cost-effective cardiac intervention and cardiac services to the marginalized population. So we need to have a better understanding of disease and pathogenesis and genetics. Since in last 70 years, we are not really done enough research. We are not invested in any new research. Genomics has been done even for Indian population in UK and Australia, but we need to have study done on a large population in India itself. And we need to have an effective approach to the primary prevention. It's not really the domain of primary the cardiologist. So we need to really invest in more of it primordial prevention and primary prevention. We need to invest for streptococcal vaccination. Still, if you go by the fast mode pathway, it may need another 10 years to really be ready for a clinical trial on a large basis. And we need to have a mechanism to really identify and treat strep throats at the earliest. And very important is, though in the West, in US or advanced countries, this is nearly the disease has disappeared. But still we have a country like Nepal and Bangladesh, who in numbers has been doing better than us. They have a GDP less than us, even having a bad healthcare structures. But going by numbers, they have been doing better. So how they have really done is that they have made their healthcare more affordable. They have strengthened their primary healthcare. There has been advocacy for early treatment of strep throats, and they have Nepal has really established a population-based surveillance system. And a couple of important slides. What could be our role in really to handle this enormity of the problem we are facing? The most important is that what has been lagging in the last decade has been the advocacy. So being a powerful body with in huge numbers, so we need to really process along the policymakers to integrate into a national program and make it a notifiable disease. I think next 2 years or 3 years, I think we should be having expert committee meeting, and we should be meeting with the Ministry of Health and policymakers so that we can integrate into a vertical national program. So we should, with NMC, I think we should ensure that the RF-RSD academic, it goes into the academics of MBBS, MD, and DM programs. And as Bangladesh has done, so they have made it mandatory to from class 6 to class 8, that identification and management of streptococcus sore throat is being taught as a chapter, so that even the school children and the teachers can identify who are the school kids who are suffering from the streptococcal sore throat. And the major problem in India, what we are facing is that the RSD is drowning the conundrum of coronary disease. We are facing this huge epidemic of coronary disease. Young cardiologists are losing interest, but let it not be a dying science. We need to keep talking about it so that the interest remains in RF-RSD. So advocacy has to be there, that we need to talk with the pharma industry so that we can make it penicillin is available, quality penicillin is available to all. And we need to ensure that we are able to give a free treatment to people who need PTMC or need cardiac surgery. We need to have a active surveillance. So we need to coordinate with all our state CSIs to encourage them to start population-based registries or have an active surveillance program. So at least they should own one district where they could do a echocardiographic school health services. And if not, at least we should establish, all cardiologists should work actively to start hospital-based registries in their hospitals. And we could share the data like how we are sharing for the NAC Council. So that at least we'll have some new data coming up on yearly basis, whether we are improving or we are deteriorating. And CSA should generate more awareness. Health education material should be available on our CSA site so that people can access it. If some cardiologists want to organize a local camp or want to have awareness program, so you should be able to access this educational material from our site. We should be able to generate this awareness about strep throats, acute rheumatic fever and rheumatic heart disease among our pediatrician friends, patient friends, and public health officers in the community, because it's just not the domain of only the cardiologist. And we need to have more space of RF-RSD topics in the annual conference of pediatricians and physicians, so that at least this remains kind of a topic for the discussions. And we should encourage echo training to the physicians. We should at least be able to train them. So at least our screening rate will improve for diagnosis of rheumatic heart disease. And in the end, we need to have a phenomenon called education in continuum. So since a lot of people are losing interest from rheumatic heart disease to getting interested in coronary artery disease, but we need to rekindle this interest. I suggest that we should have at least a book on rheumatic heart disease pertaining to our Indian context, and we should have a special supplement issue on rheumatic heart disease in Indian Heart Journal. And we should be contributing our research publication not even to Indian Heart Journal, but to the pediatric and medicine journals. And we should identify at least some center of excellence and high volume centers for the cardiologists and cardiac surgeons, so that they can learn the procedure like PTMC, and surgeons can really learn about mitral valve repair or aortic valve repair. And at least we should be offering some travel grants to young cardiologists who are really serving in this less privileged population in endemic areas as an incentive. And in the last two slides, research, it has taken a backseat. Nothing has come in last 70 years. We have been looking up to West to share us with something new thoughts, but nothing has come because they have lost interest, and they are not really handling this disease. So new, innovative, integrative, and collaborative research from different scientific bodies in India into the core issues of immune mechanisms, immunomodulation, neodrugs, and genomics. And we need to take help of our friends from digital technology, artificial intelligence. We should have more app-based registries, so where we can have a better surveillance, looking into better drug compliance and management of the patients, so that they have less complications, and which will in the end reduce to reduction in mortality. And we should award people who have been really working decades into this thankless job. I just hope that we start in Professor Padmavati annual oration on the theme RSD on annual basis. And we should be at least having one award for innovative research in ARF and ARSD in annual CSC conference. And we should be encouraging and awarding our DM students who are doing research in acute rheumatic fever and rheumatic heart disease. I think on this day, I wish and hope that we all join hands, taking a pledge that whatever we can do, let's put our best foot forward for control of this preventable disease. Thank you very much.
Thank you. Thank you, Dr. Asatra, for giving a brilliant exposition on the current status of rheumatic heart disease and laying the guidelines for what the CSI can do on this aspect. At this point of time, I am proud to announce that 468 live logins have happened to this particular program. We should be proud that our cardiologists have not really forgotten about rheumatic heart disease. They are still supporting us. That should be part one of your achievement today. Now I have Dr. Devbrata Roy, Dr. Mrinal Das, Dr. Kajal Ganguly, and Dr. Subhasis Rachadu with me, and Dr. Sanjay Tyagi and Dr. PC Rath on live. Sir, Dr. Sanjay Tyagi, sir, any comments from your end?
What I feel is that the more training for this mitral valve repair centers who have excellence of mitral valve repair should train their cardiac surgeons from different centers in mitral valve repair. That may be additional help. And the government should subsidize their PTMC for the poor, particularly for poor patients. That will help to live a longer and healthier life in these patients. Another problem that occurs is that in the rural areas, the difficulty is that of giving benzathine penicillin. The physician does not want to take the risk of any anaphylaxis which may develop, which is although it is not common, and availability of oral penicillin is also low. I think we from CSI can write to the Ministry of Health and make the availability of oral penicillin also available in different centers so as to reduce the burden of rheumatic, this sore throat causing rheumatic fever.
Thank you, Dr. Tyagi. Dr. Roth, sir, Dr. Roth, sir.
I think nowadays the treatment part is almost majority are covered with insurance. Anybody having a valve problem is covered for treatment valve for PTMC or surgery. That is not the issue. Issue is
Depends on the state that you live in.
identification.
Depends on the state that you live in. Like in
Most of the state. I am talking about Odisha. I am talking about Telangana. I see Andhra Pradesh. Everybody is covered. Only thing is identify to find out who are the patients in the rural area, in interior rural area. They have to be screened and they have to be through social organization. They have to be brought to the nearest hospital. Facilities are there provided by the government. Identification. And the other thing is the primary prevention and those things in the school health program, there should be more emphasis on that. Screening, identifying patient throat infection and treating them, that's the thing. But existing valve disease, those who have got, I think majority are covered with different schemes. They have to be brought to the hospital for treatment. I think Delhi, it must be everybody must have been covered with Ayushman Bharat or your
Ayushman Bharat is not applicable in Delhi.
Delhi, you have the state government thing, no?
The state government has not implemented the Ayushman Bharat.
Here in Telangana and Odisha, Ayushman Bharat is also not there. But their state is it's more, I think the Odisha, they have before this government came in, now they are going to introduce Ayushman Bharat, 90% were covered. And the year was higher. The payment was higher than the Ayushman Bharat. In Telangana also, they have a state scheme, and most of the people are covered. And again, it's better than the Ayushman Bharat. So I think in that way, only as I told you that identifying them and bringing them to the hospital for treatment is the issue.
Okay. Okay, sir. Dr. Mrinal Das, Could you
Yeah,
some comments, please?
I'm thankful to the organizers for organizing this particular event, which is very, very important to all of us. But since I am in a private setup, so I must tell about this fact that we encounter very less number of cases of rheumatic fever or rheumatic heart disease. Really it's a fact which is observed by many other people also. This is number one. Number two, I happen to be the convener of the Rheumatic Heart Disease Council in 2012, and during that time when I planned for collecting the data and I went to the medical colleges, I had a very, very bad experience that there is no record keeping whatsoever in the colleges, where actually more of the patients of rheumatic fever and rheumatic heart disease come rather than in the private setup. So this is number two. Number three, I think most of the points have been covered by Dr. Sanjeev regarding the role of CFI in rheumatic heart disease prevention or management. What I would suggest that if the Himalaya cannot come to the Muhammad, then Muhammad should go to the Himalayas. So in that way, we should go to the rural setup, especially the IMA and all these other small the organizations who are involved with the sort of general practitioners and more involved with the patients but at that age group, particularly between 5 to 15 and all. There possibly we can collaborate with them to have some data, and that data will give us more information, will give us more strategic planning so that we can do better. Right now, there may be some availability of the individual data collection or institutional data collection, but not at the level of the organization. And I do emphasize on this particular aspect where we can do something. And of course, year before last, Dr. Debabrata Rai, the secretary or the past secretary, he took some initiative on the AI application of AI in rheumatic heart disease by collaborating with Accenture, this company. And if we can really go through, I mean, can avail that facility, then possibly more detection of the cases of rheumatic fever, at least the subclinical cases of rheumatic heart disease can be found out.
I think to me, as I was in public government sector for a long time, I have seen different stages of this rheumatic fever. I also tried to have this data for rheumatic heart disease in our society, but it's a huge task. So I think at this point of time, primordial prevention is more important. That's how it can be prevented in the society. And for that, we should involve the IMA people, those who are initially seeing the rural people, and also as Dr. Debabrata has taken the initiative into the school. So they can identify early these cases of rheumatic fever and then treat it accordingly to prevent this menace of this disease in the long run.
Yeah. Thank you very much, both Dr. Roth sir and Dr. Asatra. Unfortunately, I missed deliberation of Dr. Taggi. So I think we had a very interesting discussion on Rheumatic Heart Disease Day. The CSI so far, what it has done, it has initiated a project to detect subclinical rheumatic heart disease among school children by utilizing app-based detection of markers through digital stethoscope acquired signals. So this is the project we are working on, and we have launched a pilot project and see how effective it would be.
This is a serious issue because so far echocardiography remains the gold standard for detecting subclinical rheumatic heart disease. But as we all know that the necessary logistics and the infrastructure may not be possible in the distant schools which are located at the distant areas. So we are working on that, and when we have taken it with other societies, a lot of interest has been created, especially among the Latin American countries. And so we'll see how the project fares. And taking a cue from Dr. Asatra, what I'm thinking that we can integrate this project with creating some awareness about sore throat.
Link is not there. Huh?
Not. In connection.
लिख देते हैं लिखने में
We have some power outage here, but it is now corrected.
Yeah, so I think we are shortly will meet on 6th of July, and we can definitely we can integrate this with the our ongoing programs on air pollution and cardiovascular disease awareness as a whole. We can integrate this.
Subhashish, Professor Subhashish Rajagale,
Assistant
Secretary.
Good evening, Rockstar and Kagi sir. There was one point we wanted to make when I'm listening to Pastor's talk is that I think there is a increasing awareness about these things, increasing interest for rheumatic heart disease, especially even for junior colleagues and our residents. So definitely the way to promote it would be to have more best papers, best theses on a national level. I think that should be the first way to promote the junior colleagues. Strongly suggest that we do something like that.
Thank you, Subhashish. So, like all every good things, this program will come to a close. Before I go, I would like to inform you that as Dr. Roy was talking about, the World Heart Federation has divided the echo screening program into two parts. One is a basic or a level 1 screening. We are planning CSI with the
Joining in 1 minute. They're facing some power issue. 1 minute, they'll join back.
Sorry, we are facing some problems with the power supply here. The generator is not giving us continuous backup. But anyway, as we are talking about that, we are planning something it will be on anvil, and we will with Dr. Asotra will be discussing it in the Chennai NIC. Dr. Asotra, you are attending, I believe.
Yes, yes. I'll be coming, sir. I'll be attending. Yeah.
Therefore, we will have a meeting with you and myself and Dr. Roy, and we will be discussing this. Huh? And Ajay Bal. And Dr. Ajay Bal will be there. And on this note, today I must thank you all for very successful Rheumatic Heart Disease Day. Thank you, everybody.
Thank you.
Thank you, sir. Thank you very much.
Thank you very much.
Goodbye.
Bye, sir.
Bye.
Bye.
Good day, sir. Good day. Good day.
Record